this presentation is intended for US-based medical care professional audiences only. It's an educational program about Alzheimer's disease, and we will not provide any clinical guidance or diagnostic advice. So Drs. Trin and Gittleman, again, a warm welcome to you, and thank you so much for joining us today. Dr. Trin, can you introduce yourself, please?
Sure. Yeah, my name is Young Trin, primary care physician for almost 20 years with a large health system here in Southern California, and have transitioned after taking care of many of my own patients who I've seen the entire timeline and process of Alzheimer's. I've transitioned over now to the world of Alzheimer's health education, clinical trials, and medical research with that.
Great, thank you so much. Dr. Gittleman?
Thank you for having me on the panel. I'm likewise excited to be here today. I'm a behavioral neurologist, and as you said, the senior medical director at the Advocate Memory Center. I've been caring for patients with Alzheimer's disease and other forms of dementia for about 30 years now. Initially, did research focused on structural and functional magnetic resonance imaging of brain disorders, but in the past 12 years, have focused more on clinical trials for reducing dementia risk through lifestyle modification, trials focused on genetic forms of Alzheimer's, and also trials on sporadic AD, which is the most common form of the disorder. Thank you.
Sure, thank you. So in our discussion today, I'll start off by giving you a little background about ASI, and to say that we have been conducting research in Alzheimer's disease for over 4 decades. And with our partners, both Biogen and BioArctic, we are committed to this disease area and to serving the AD community. So I'm delighted to provide a review of the topics that we're going to cover. So we'll look at Alzheimer's disease, the mechanism for the disease, and clinical changes in early stages. We'll talk about blood-based biomarkers in AD diagnosis. We'll touch on protofibrils in AD progression, and then we'll look at evaluating clinical data in AD clinical trials. So let's start off by talking about the mechanism of disease and the clinical changes in the early stages of the disease. So Dr. Trin, may I ask you, what is Alzheimer's disease and how is it characterized?
So Alzheimer's disease is under this umbrella of what we call dementia. And so under this dementia umbrella that includes all types of cognitive issues, Alzheimer's disease take up probably 2/3 of the umbrella. And it's a type of dementia that affects memory. It affects also thinking skills, as well as function and activities of daily living. It also affects behavior and personality changes as well. We know that this is a condition that is chronic. It takes years over time to develop. We know that it's neurodegenerative. What that means is that we lose brain cells, and so neurons in the brain are dying, and that this disease is progressive and irreversible when it comes to neurodegeneration and brain cell death.
Yeah, just wanted to add to the important points made by Dr. Trin. The Alzheimer's Association group and the International Working Group, importantly, both groups agree that Alzheimer's disease biomarkers are critical in establishing the diagnosis. The Alzheimer's Association group defines what they call the core 1 biomarkers, which measure elevation of amyloid. This could be by positron emission tomography, cerebrospinal fluid, or plasma biomarkers. And patients with elevated amyloid are said to have AD whether or not they have clinical symptoms. Mm-hmm. And this group has a staging scheme to kind of understand the mismatch between the biomarkers and the neuropathology and the clinical expression of the disease.
So, Dr. Trin, would you be able to expand on the pathogenic events behind the development of Alzheimer's disease and highlight some of the key pathological features of this disease?
So the key pathological features of Alzheimer's disease includes the presence of the beta amyloid plaque, and also the presence of what we call tau tangles, neurofibrillary tangles. We know that if we did an autopsy of a patient with Alzheimer's, we will always find the amyloid plaque and the tau tangles. The other things we see as key pathological features is the loss of brain cells over time. That's neuronal loss. As we're losing brain cells, the brain cell's ability to communicate, to chat, also is disrupted. We call that synaptic dysfunction. The synapse is the location where brain cells communicate and connect. And so we lose synaptic dysfunction, we lose brain cells, and the brains die, and we have brain atrophy,
Mhm.
essentially, is what we see. And on top of all that is inflammation. There is a lot of neural inflammation in the brain that is associated with Alzheimer's disease as well.
Dr. Gittleman.
Yeah, thank you. So Alzheimer's seems to start with this imbalance between, and there's a lot of debate. I know people who focus more on the tau portion of Alzheimer's, the amyloid portion, but there's a lot of evidence, genetic and otherwise, that there's some imbalance between A beta production and clearance. There can be overproduction of A beta, seen in some genetic causes or ApoE4 carriers,
Mhm.
and reduced, degradative mechanisms and clearance through the CSF or perivascular spaces or lymphatic mechanisms. Once A beta accumulates, various mechanisms seem to lead to misfolding of the protein and then accumulation into various amyloid species, oligomers, protofibrils, fibrils, plaques. What seems clear is that some of these species appear to have significant toxic potential, and then the formation of the A beta fibrils seem to potentially autocatalyze other A beta molecules joining these fibrils and also lead to tau accumulation.
Mhm.
Interestingly, all of this starts many, many years before a clinical diagnosis of AD, and we can now detect this with a lot of biomarkers.
Right. And so now, Dr. Trin, I invite you to help us and to explain the role that tau plays in AD pathophysiology.
So the tau protein itself is a healthy, normal protein that's inside of a brain cell, a neuron. And the tau protein plays a role. It is part of a structure called the microtubule. And the microtubule essentially is kind of like the rebars of the cell. It provides structure. It also is kind of like a highway where nutrients and messages are transported back and forth. So, so a healthy tau, part of a microtubule, is normal. What happens in Alzheimer's is that the tau becomes phosphorylated, this phosphate group that attaches to the tau protein in Alzheimer's disease. And that phosphorylation causes the tau protein to dislodge from that microtubule. In the process of dislodging, the tau protein misfolds. And as it misfolds, these phosphorylated tau, as it misfolds, it becomes tangled, which is why we call it neural fibrillary tangles of tau.
Right.
And that leads to the death of brain cells.
Okay. Thank you both for providing this background about the role of both A beta and tau in the development and progression of Alzheimer's disease. And it's really critical for us to diagnose AD as early as possible, given that, as you both said, the changes in the brain precede the clinical symptoms. And that accumulation of A beta um, kind of facilitates this ongoing process, and that precedes other physiological changes like tau. And then we see neuronal loss and we see damage to the brain. And that process becomes irreversible. So it's important to identify these people so we can intervene if possible, whenever possible, as early as possible. So Dr. Gittleman and Dr. Trin, would you take us through the stages of Alzheimer's disease along with some of their clinical features?
Dr. Trin, did you want to go ahead?
Sure, I can talk about the stages of Alzheimer's disease, which is broken down into three stages. The mild stages, moderate and severe. In the mild stages, individuals may experience some memory lapses, such as forgetting recent events, forgetting names. They may misplace items and struggle with decision making. Sometimes we'll see mood changes that includes agitation, anxiety, behavioral changes. But all in all, most folks with mild Alzheimer's can still function relatively independent.
Hmm.
When we move on to the moderate stage of this disease, memory problems begin to worsen. And in the moderate stage, many of our patients do require some assistance with daily activities at home. And when we progress from moderate to severe, which is the late stage of Alzheimer's, these are the patients that typically are in nursing homes. These individuals lose their ability to communicate, they lose their ability to perform just basic tasks of activities of daily living. These individuals require typically round the clock care and will experience severe cognitive decline, immobility, incontinence, and often mood and behavioral changes such as hallucinations are pretty prevalent. So those are the three stages of Alzheimer's disease.
Okay, thank you. So indeed, we can see how there's this progressive nature of Alzheimer's disease, and it appears that if we intervene early, we have the greatest potential to have the best and the most important impact. And understanding and recognizing these early stages, such as mild cognitive impairment, is so very important. So may Dr. Trin, I ask you to just further expand on MCI and the subtypes that we may see in MCI.
Yes, so MCI, mild cognitive impairment, characterized by noticeable changes in both memory, in cognitive abilities, such as language, attention, reasoning, but they're not severe enough to affect activities of daily life, right? Not severe enough to affect daily function. So that's where someone is determined as to having MCI uh, with that. And again, it's distinct from dementia in Alzheimer's dementia in that it does not significantly impair activities of daily living. You're still pretty independent.
Mm-hmm. Great.
Yeah.
Dr. Gittleman, can you expand and talk about some of the defining subtypes that we find in the MCI population?
Yes. So important to note that MCI includes an understanding of both the patient's cognitive and their functional status. Sometimes I see people who are labeled as MCI who it's because they're newly reported to their primary care doctor as having memory loss, but they actually may be quite impaired functionally. So you want patients who are really mild at the cognitive stage generally, and also, again, largely independent in their daily activities. Also, I note that MCI is very dependent on the quality of the history. So patients may be reported to be independent, but they really are increasingly supported by family or friends, or they may be independent, but in an increasingly restrictive environment. So they function in their home, but if they travel, they'd be utterly lost. There are a number of subtypes of MCI, and it can be divided into amnestic and non-amnestic varieties. So it's recognized that often in Alzheimer's disease, we see this amnestic change and memory loss as a defining feature. But now, as in different subtypes of Alzheimer's, there are different subtypes of MCI. So you can have MCI more focused on language deficits or perceptual visual spatial deficits or executive frontal deficits. And there's also single domain MCI where a single area such as memory is affected, or you'll see single domain MCI when people may eventually present with disorders such as posterior cortical atrophy. They might have those perceptual deficits first, or primary progressive aphasia, and they'll have those language deficits first. So you can have single domain and multi-domain MCI. And these have been associated with perhaps early precursors to different types of dementia. So the amnestic type, often seen with Alzheimer's disease. Multi-domain, you might see with more vascular dementia. Perceptual difficulties, you can certainly see with Alzheimer's, but Lewy body dementia. And of course, a frontal executive with frontal dementia.
Okay, thank you. That's really important information that you've shared with us. And it really reinforces the importance for early detection, as that offers us the opportunity to provide care before the disease really progresses and worsens. So, Dr. Gittleman, can you provide examples of changes in the early stages of AD and some of the screening protocols that you might use clinically when you're evaluating and looking for these early stages of the disease?
So I like the Alzheimer's Association early warning sign list. I think it's a really good list.
Uh-huh.
And it mentions things like, of course, memory loss that disrupts daily life. That disruption is important. There can be challenges in planning or solving problems. They may struggle. Patients with more difficulty completing what should be familiar tasks at home. Some confusion about time and place. They may misperceive visual images or spatial relationships. There can be new problems with speaking or communicating or writing.
Hmm.
They misplace things. Patients may not be able to retrace their steps. Decreased or poor judgment. Often we hear that people are just quiet, right? They're in a family or a friend setting, but they just don't participate in the conversation anymore, or they've withdrawn from social relationships.
And Dr. Trin, can you explain to us some of the screening protocols that may be most effectively used by HCPs to help them identify who may be living with the early stages of Alzheimer's disease?
Yeah, so in the primary care setting, screening is often done during an annual wellness visit or a physical exam. And during that time, uh, when our patient comes in, obtaining a patient history is very important as part of screening, and not just from the patient, but oftentimes from a spouse or a caregiver or another informant of their observation of that patient. And in that history, we would normally ask directly, are you having problems with your
Mhm.
memory? Are you having any concerns with remembering, and has it been progressive over time? Are you having any concerns with doing daily activities? Is your thinking skills affected? Have you been able to do taxes every year, and now it's becoming harder to do? Is it harder to balance the budget? These are thinking skills that we evaluate as well
Right.
as just memory and cognition. In this patient history, it would include past surgical history, social history. Do you smoke? Do you drink excessively? These are, again, risk factors for Alzheimer's disease. We would go over medication lists. Are there medications that may affect your memory? Are you taking supplements that can interfere with cognition and things of that sort? And that goes on to the next step, which is a physical exam, a neurological exam, where we would check your cranial nerves, check your motor strength, reflexes as part of the neurological exam. Physical exam, I would listen to heart and lungs and things of that sort. We know that those who are at risk for heart disease, all those same risk factors are the risk factors for Alzheimer's disease. So very important to collect that type of medical history, reviewing their medications. The cognitive assessments that are normally done in primary care, the top two that most primary care physicians are familiar with would be the what's called the MMSE, the
Mhm.
mini mental state examination, and the mini cog, which is kind of a shorter version of that MMSE. Primary care providers are very familiar with that. The other cognitive assessments that are available, done either by primary care or more often with the specialist, would be the MOCA test. That's the Montreal Cognitive Assessment Test. So those are some of the assessments that we do in the office and the way we approach screening.
So, Dr. Gittleman, can you tell us about some of these new digital tools that are coming as screeners?
Yeah, thank you. So one problem with a lot of the tests, the MOCA, for example, and mini mental, they take a lot of minutes, and primary care doesn't have any minutes, to test people, unfortunately. So there are new tools under development that may allow testing patients in their homes, for example, or to have a shorter testing time
Hmm.
while still maintaining the same sensitivity and specificity. Some of them are based on a gamification of familiar tests, for example, wordless learning, fluency tests, trails A and B, and so on.
And we know, and just by what you've said to us, the screening tools are extremely important in helping to detect cognitive change. And as we know, assessing cognition and establishing that there is a cognitive impairment is essential before we do more sophisticated kinds of testing with the patient. Dr. Trin, can you explain what HCPs should be looking for in patients to differentiate between normal aging and early cognitive change that would be associated with an Alzheimerization process?
Yes, so normal aging involves mild forgetfulness, occasionally forgetting a name, occasionally misplacing items. But patients often recall them later on. And the memory loss is kind of intermittent. It's not progressive over time. It doesn't get worse over time. That's normal aging. It does not interrupt daily life or the ability to perform tasks. Uh, in the memory or cognitive changes associated with Alzheimer's disease or early Alzheimer's disease, you have memory loss that initially at the MCI stage does not interrupt with life, but as it progresses, we see that it interrupts with daily life.
Uh-huh.
Difficulty completing tasks that are familiar, driving home, and all of a sudden, where am I going? Where am I? Confusion with time and space and season and things of that sort. Again, new problems with words in speaking and writing that progresses and worsens over time. So language issues, decrease or poor judgment. You're cooking and then you forget to turn off the stove over and over again, or the keys are now in the refrigerator. Why is it there? And also we see changes in mood, behavior, and personality as well. That differentiates
Mm-hmm.
aging.
Dr. Gittleman, can you add some things to this?
Right. So I think it's important for a primary care to know that so normal aging shouldn't substantially interfere with performance of daily living activities. But of course, if we wait for those to change, we may miss the MCI stage. Another important thing is just for primary care physicians, and we have to provide that education to understand the importance of early identification of cognitive deficits. So it's not something now where you would say, well, of course you're 80, what do you expect? You're losing your memory. But to just understand that detecting these changes early may allow for these new interventions. Ask about functional performance of patients. Try to get independent collaborations from family members and do some testing. I mean, if it's possible in the clinic where you have staff that can do the testing or some of these new digital tests that can be implemented, the objective tests are very important, or refer the patient for some testing. And so if the patient is mentioning symptoms, it may be important to get further evaluation.
Thank you. Thank you both for sharing what you see clinically and what patients and families see, and their friends too, so that all of us are better taking care of the people that we love. So let's transition to another topic. Let's talk about biomarkers. And we know, as you both have suggested, that biomarkers are playing a much more important role in the diagnostic evaluation for Alzheimer's disease. And it's not uncommon that a diagnosis, if it's made clinically, could be delayed. And many individuals do not get diagnosed for 2 or 3 years after some of the symptoms that you have spoken about really come through. So I think we all can agree that it is critical and it is an unmet need for us to be able to access biomarker testing for Alzheimer's disease. So, Dr. Gilderman, can you explain how biomarkers help us in the diagnosis of AD?
And so without testing, I mean, we see patients, it's just been an amazing eye opener that with biomarker testing, you can have a patient that for all the world seems to have Alzheimer's disease, but then they turn out to have some other cause of their dementia, vascular, limbic predominant, age-related TDP-43 encephalopathy or late, Lewy body, and so on. So it's really been an eye opener and important to use biomarkers in testing.
Mm-hmm. Can you tell us about some of the traditional biomarkers that have been used, like PET imaging and CSF testing?
Right. So PET, amyloid PET, is a current standard for disease-specific biomarker testing. Spinal fluid measures amyloid and tau species, and again, is for disease-specific biomarker testing. These are accurate and well validated.
Mm-hmm.
But now blood-based biomarkers are increasingly accurate, and I think are likely to become a standard within the next couple of years. There are a number of limitations with PET and CSF that can be very expensive, and you need a PET scanner, and you need a source of radio tracer.
Sure.
Spinal fluid, not something often done in primary care. So these new blood-based biomarkers may be a way to get testing out into patient care.
Yeah, absolutely. And Dr. Trin, can you expand upon how blood-based biomarkers may be used and could be available compared to other of the current markers that are in clinical practice?
Absolutely. This is a very exciting field. As a primary care physician, we have always made the diagnosis of Alzheimer's based on what we can rule out, right? We've ruled out a stroke, it's not medication side effects, and so as a result of ruling out all these other conditions, this must be, Alzheimer's based on that. So now with the presence of biomarkers, we can now rule in a condition rather than waiting to rule out all these other conditions. And it improves, obviously, the accuracy rate of this diagnosis. There's more than one type of blood-based biomarkers being evaluated. There is the most popular one currently, as of today, is the p-tau217, which is phosphorylated tau217. But we have also looked at plasma AB42 to 40 ratios,
Mm-hmm.
looked at the p-tau217 to the non-phosphorylated tau ratio. And so with the onset of these biomarkers, we're able to improve the accuracy of this diagnosis and hopefully make the diagnosis certainly earlier than waiting for significant symptoms to occur. They are compared to, let's say, a cerebral spinal fluid lumbar puncture. Obviously, these blood-based biomarkers are less expensive, potentially less invasive, and so very exciting compared to, let's say, a PET scan. A blood-based biomarker may be certainly more available to the clinic. Not every clinic is close to a radiology center that has an amyloid PET scan or tau PET scan. We're using this obviously in clinical trials, and it helps over time to better find that patient for clinical trials and find them more accurately.
Absolutely. Dr. Gittleman, I invite you to kind of tell us about using these blood-based biomarkers as screeners of AD pathology, and what about their use in normal people?
Right. So they are much easier to get, as Dr. Trin pointed out, than undergoing a lumbar puncture or even a PET scan. Radiation exposure, the cost is less. I think that there's a real use for them now, particularly in screening for research, clinical trials.
Mm-hmm.
So making that diagnosis, I mean, it's amazing that the first amyloid targeting clinical trials, they realized, when they looked at amyloid PET scans, that a third of the people didn't have Alzheimer's disease in the trial. So how can you do a trial that way? So now the screening is much less expensive. You can bring in people more easily to the trial. I think that current diagnostic criteria really discourage asymptomatic testing in patients. So I think these biomarkers are really for symptomatic people or clinical trials.
Mm-hmm. And what about medical conditions? How do they affect the blood-based biomarker tests? What is their impact?
Yeah, that's important. Dyslipidemias, hypertension, diabetes, chronic kidney disease, stroke histories, a number of these disorders can really affect the levels of blood-based biomarkers, particularly when you're measuring just a single entity. So rather than just p-tau217, now the ratio p-tau217 to non-phosphorylated tau is being used, and it will discount the effects of things like renal dysfunction, for example, and is more accurate.
Okay, thank you. Then, Dr. Trin, what about the current guidelines? How are we using them clinically? Can you tell us about that?
So the current guidelines and protocol, as recommended by the Alzheimer's Association, is to start blood-based biomarkers and to use it in specialized memory clinics for diagnosing patients who have cognitive symptoms, and then to confirm the results of PET scans or CSF. But more data is really needed before using these blood-based biomarkers as a sole diagnostic tool in all clinics in the United States.
Mm-hmm.
But we're heading definitely in that direction. It's a very promising tool that is less invasive than a PET scan or a lumbar puncture. It should be more accessible because it's a blood test compared to going to an imaging center, and more feasible at the primary care level to implement.
Agree, agree. Thank you so much, both of you, for giving us this current update on blood-based biomarkers. And the field has really developed all over the last few years, although, as you've noted, that there's a lot more research that's necessary to be done in order for its widespread use to be clinically done. So now I'd like to transition over to another topic. So we know that AD biomarkers confirm the neuropathological events that are characteristic of Alzheimer's disease. And it's really important for us to kind of go a little deeper and to understand what happens to the amyloid beta after the protein, the amyloid precursor protein, is cleaved. And that cleavage then begins to have different aggregated forms of soluble and insoluble structures. So, Dr. Trin, can you describe the amyloid beta plaque and how understanding the science and the development of those plaques is critical for AD management?
Sure. So the amyloid plaque is the end result
Mm-hmm.
of what we see in an Alzheimer's patient. But before the plaque became a plaque, it took several steps to get there. And I'll tell you the specific steps of how a plaque became a plaque. The amyloid precursor protein is a healthy, normal protein that is found in the walls of our cells, especially in the brain. And depending on how the amyloid precursor protein gets snipped, right, gets cut, it could go into the direction of alpha amyloid or amyloid alpha, which is a direction that does not lead to Alzheimer's disease, or it could go toward what we call amyloid beta, beta amyloid. And the first part after the snippet of the APP protein, you have what's called the monomer, the amyloid monomer, right? And one monomer gets together with another monomer, and you create the dimer, the amyloid dimer. And as more dimers connect, the oligomer, the amyloid oligomer is formed, oligomers connect, and the protofibril is now formed. Now, this is all still in the soluble state, meaning liquid form. After the protofibril stage, when protofibrils connect, we create an insoluble fibril. And that insoluble fibril, as they connect together, becomes what we now call the amyloid plaque.
Mm-hmm.
But it's important to note that the toxicity to the brain does not start at the plaque level. It actually starts at the insoluble level, where the oligomer, the protofibrils themselves, can be neurotoxic with that.
Mm, thank you. Yeah, the cascade hypothesis and that model has really been a focus of AD research for a very, very long time. And Dr. Gittleman, can you explain protofibrils and their role in the development of AD?
Well, basically, as Dr. Trin said, they're really large but soluble aggregates of oligomers. And the protofibrils are really produced, once that AD process starts. Even if therapies are used to clear out the plaques, for example, protofibrils can still be made. They are considered to be toxic. So even without the plaques, you can have toxicity. They
Right.
seem to be directly neurotoxic. They seem to induce synaptic dysfunction. So potentially reducing some of these earlier amyloid species is important for treating the disease.
Well, thank you so much for sharing how protofibrils play such a significant role in the development of AD and disease progression. And as we know, the A beta cascade hypothesis posits that A beta pathology precedes the presentation of symptoms and the other downstream effects that we see neuropathologically. And it's been thought that if we target these A beta species, the aggregated soluble forms, like you said, oligomers and protofibrils, as well as the insoluble forms of the fibrils and the plaques, that this could be a way in which we could address and target the disease. For example, clearing protofibrils is one approach that's thought to interrupt the cycle of full plaque development and neuronal injury, but more to come. So now let's talk about some evaluating our clinical data and AD clinical trials. And Alzheimer's with our partners Biogen and BioArctic, we're taking steps toward understanding the key role that A beta and specifically protofibrils play in the development and the progression of Alzheimer's disease. But let's examine and evaluate some clinical data in AD to help HCPs with their diagnosis and patient management. So, Dr. Gilderman, I invite you to explain some key study design features in Alzheimer's clinical trials that may be important for one to consider.
Right. Papers reporting on these clinical trials should be carefully read. What's the objective of the study? Was it safety? Was it efficacy?
Mhm.
Assuming it's a phase 3 study, it's probably both safety and efficacy. Biomarkers we've talked about today are so important for making the diagnosis, and they are monitored in clinical trials, but they're not sufficient to just approve a new AD treatment fully. Although accelerated approval may be given based on biomarkers, full approval really still depends on knowing the patient's this kind of dual approach, clinical and functional measures. Um, I think it's important to know the composition of the study, what the
Mhm.
age range is, what the gender distribution is, and that there's been diversity in recruitment, among a number of minority populations. Sadly, some recent trials have not had as diverse recruitment, and then it's hard to know how the results may apply to different populations. We know that Black Americans, for example, may have lower levels of amyloid, but still have more cognitive impairment. So how do you measure that, and how do you approach the treatment of different populations is important. It's important to consider the length of the trial. Disease-modifying trials are going to be longer. Symptomatic trials may be shorter because it takes time for those disease-modifying trials, to show the change over time. Look at the inclusion and exclusion criteria. This will really have a bearing on how the trial applies clinically. So if a trial excluded ApoE4 homozygotes, for example, it's going to be difficult to know how the therapy applies to them later. So looking at what populations are included, particularly the newer therapies, there are a lot of risk to those therapies. Which populations were targeted, which were allowed to be in the trial, can inform which patients to include when you decide on treatment.
Sure.
And as I mentioned, those clinical and functional outcomes, behavioral outcomes, are important as well.
Can you elaborate a little more and talk about how some study design factors that you just mentioned can impact the trial results that we see?
Right. So, as I mentioned, the patient's age, gender, genetic backgrounds are important. The presence of ApoE4 or not may have factors related to the the adverse events in the trial. What stage of patients are included is very important. Current disease-modifying trials are really focused on MCI and AD and mild dementia due to Alzheimer's disease, whereas earlier instances of amyloid targeting therapies included moderate disease, but wasn't found to be effective. What comorbidities were allowed is very important. And could the trial result in unblinding events? So if people experience an adverse event, now they may know what treatment they are on. Although we did have a patient in the trial who every time he got an infusion, he'd have a headache. Later, it turned out he was on placebo. So you don't always know. But
Right.
there are events that occur that can unblind. And look at the participant dropout rate. Are most of the patients finishing in the trial, suggesting it's going to be useful clinically, or not finishing, and then suggesting that there are barriers in terms of administering the treatment or in side effects.
Mm-hmm. All right. So thank you. That's important. And it's important for the world to know that at ASI, we aim to really develop trials where the study design is really reflective of the real world of AD that we see clinically. So Dr. Trin, is there anything else you want to add? Any common examples or methods that are used to select the appropriate patient for clinical trials?
Yeah, everything Dr. Gittelman said, and want to also emphasize the importance of diversity and equity and inclusion in these studies, because again, our studies need to reflect real life. Our studies need to reflect the community where we live in. Again, we know that African American have twice the risk of Alzheimer's as a white American, or Latino Hispanic American have 1.5 times the risk of Alzheimer's than a white American, and so it's very important to consider including everyone into these clinical trials so that we get real world data with that.
Thank you. Yes. Dr. Gittleman, anything to add to that before we go on and talk about examples of clinical endpoints?
Yeah, I think the principles of justice in human trials, but also scientific validity suggest that we really need diverse recruitment. Industry can prioritize many things in clinical trials. They prioritize ApoE recruitment, they prioritize early stage disease, they can prioritize diversity so that we know that we are applying these treatments to appropriate populations.
Great, great. So can you talk about some clinical endpoints that you think are appropriate that should be included?
Yes, I think I mentioned before, clinical trials focused on efficacy are going to, for Alzheimer's disease, likely measure cognitive endpoints, and you want to know that the cognitive endpoint is appropriate for that stage of disease. For example, the severe impairment battery, not going to be appropriate for testing mild stage disease,
Or
while the clinical dementia rating scale and ADAS-Cog and similar types of measures may be appropriate for early stage. It would be important to include measures that can be done in some fashion in the clinic so that physicians know that testing their patients, they'll have a similar outcome to what the trial showed. Other measures include behavior, so like the neuropsychiatric inventory to measure the various behaviors, functional measures, that's so important as well, a global change, so just what the physician's impression is of how the patient is doing. And then, of course, quality of life is important. And Alzheimer's always involves the patient and the caregiver. So how is the caregiver doing and what is their burden?
right. Okay. Well, thank you so much, Dr. Trin and Dr. Gittleman, for joining us today. So let me just take a moment to summarize our main points. So we know that AD is a chronic, progressive, neurodegenerative disorder that's characterized by both clinical and neuropathogenic changes. A beta deposition and specifically protofibrils play a key role in the features and the development of Alzheimer's pathology. And this area, A beta in general, is a compelling target for disease management. We know that blood-based biomarkers have the potential to transform AD diagnosis, but we also know that it needs further research before it can be really included and used clinically. We looked for clinical relevant endpoints in data and in our clinical trial designs for more clear understanding of how to manage patients in the early stages of the disease. So we invite you to visit ASI US and Biogen website and to follow us, both ASI US Neurology and Biogen on LinkedIn and in X. And links to these resources will be posted in the content below the live feed. And we thank you so much today for joining us and for being part of our LinkedIn Live event. Thank you.